I will give a quick update on prevention and treatment of congenital CMV infection. This is because there was a lot news in the last 4 or 5 years, and I think there is a big occasion to talk about this topic. So just to refresh, which is the global burden of congenital CMV, we see in this map the seroprevalence of CMV in women of childbearing age and their respective rate of congenital infection. What we know is that in industrialized countries, including Europe, where the seroprevalence is around 50 to 85%, congenital CMV is mainly due to primary infection. Whereas in developing countries, where seroprevalence is nearly 100%, it's due mainly to reinfection reactivation. This is important because congenital CMV infection is one of the most common causes of congenital infection in children, with the prevalence at birth between 0.5 to 2%. We know that it accounts for about 25% of cases of childhood hearing loss and about 10% of cases of cerebral palsy. So it's a big problem in pediatric age. And why is it important to talk about primary infection or reinfection or reactivation? Because we know that the primary maternal infection is the most common cause of vertical transmission of the virus. And we know that the timing of primary maternal infection is one of the most important factors determining the transmission rate, as we see in the study by Chazakis et al. So we see that the transmission rate increase with pregnancy, going on with the pregnancy, whereas the fetal insult, it's really higher in the periconception and in the first trimester. So what can we do regarding prevention of congenital CMV infection? We can act at different points. For sure, the first point is the first opportunity for prevention is the vaccination. There is a lot around this topic, but at the moment we don't have a vaccine candidate to offer to our women. So for sure, what we can do is to prevent congenital infection in mothers with an improvement of hygiene precaution. What we can do as a secondary prevention is the use of this drug, which is valacyclovir. We can prevent fetal transmission in case of maternal primary infection. The third steps is the tertiary prevention with another antiviral treatment with valganciclovir. We know something more about this as pediatrician, and this is to prevent severe outcomes in asymptomatic infected newborns. So a lot of news have been released by the publishing of the European Congenital Infection Initiative consensus, published in 2024. And something is about the introduction, the suggestion of introduction of CMV universal screening protocol in countries such the European countries where the seroprevalence is low. And this is the first step to detect mothers who can be treated in case of primary maternal infection in the first part of the pregnancy. That was because with this trial, which was published in 2020, we started to understand the importance of valacyclovir in the prevention of vertical transmission of CMV. As we saw, valacyclovir it's able to prevent the risk of vertical transmission by 70% in women who acquired primary CMV infection in the first part of the pregnancy. This data was confirmed thereafter in a meta-analysis in more than 500 women, confirming the effect on congenital infection prevention of about 70%. So what happened with the different countries? So Italy, since the end of 2020, approved the use of valacyclovir as a reimbursable medication for preventing mother-to-child transmission of CMV in case of primary maternal infection in the first part of the pregnancy. This was not done, for example, by other countries. We actually are really active regarding congenital CMV, like France. And that was the same, for example, for US, where valacyclovir is not yet FDA approved for the prevention of congenital CMV infection, but it can use only bioresearch protocols. This is something regarding our data. This is the first part of the study, which was coordinated by Professor Zammarchi and published in 2023. This is an observational prospective study on real-life data, which is called Megalithally study, which analyzed about 450 pregnant women in 10 centers who acquired the primary CMV infection in the first part of the pregnancy. And two cohorts were compared, the one who was treated with valacyclovir and the one who didn't receive the treatment. And in the treatment cohort, we saw a reduction of about half of the CMV DNA positive amniocentesis, a reduction of about 80% of symptomatic congenital CMV infection at birth, and a reduction of about 75% of termination of pregnancy in the treatment group. What we are going to do now is something that is done to understand which are the long-term effects of valacyclovir, because there are some points that need to be clarified. For example, the long-term audiological and neurodevelopmental outcomes in children treated during pregnancy, and the possible late-on side effects. So what we are doing now is to continue with the collection of data and analyzing the pediatric data, Italian data, with the objective to evaluate the impact of valacyclovir treatment in the clinical practice. We started to collect the data. These are just very preliminary data from November 2024. We are now just refining another call so we are cleaning data, analyzing again. So at the end of 2024, we had 170 newborns, of them 70 with congenital infection, and about 11% were symptomatic. And we have a follow-up of about 1 year of median time, but with an interquartile range going up to 4 years. In the asymptomatic cohort, we have one patient who developed profound hearing loss at 2 years of age. So what we can start to say, analyzing our data, is something regarding drug safety, so valacyclovir safety in children, as we didn't see any clinical or laboratory adverse effects potentially attributable to the maternal treatment. I'm going to go a little bit ahead with the treatment of infected children, because this is another big point in the congenital CMV infection. By now we have only few pediatric trials regarding congenital CMV infection, the big ones by Kimberlin, who led us to know something regarding valacyclovir treatment of infected children. So we had quite clearly that we need to treat children with CNS involvement and the symptomatic ones. But there are a lot of gray areas regarding treatment, for example, of isolated hearing loss or late hearing loss. Something regarding other manifestations like a UGR, hepatitis, thrombocytopenia, and the asymptomatic ones. Just quickly to show you that in the last year we had 2 more trials. One is the CONCERT trial, was published on 37 children and show improved hearing outcome in the treatment group in patients treated with valacyclovir. And the other one, which was by Kimberlin again, it didn't show advantages of treatment. But what can we see? And I want you to have a look that these trials are only on about 35, 37 patients. So this is to say how much is difficult to conduct trial in congenital CMV infection. These are the guidelines we can use, we can apply in our clinical practice to treat children with congenital CMV, to understand which patient to treat and for how long. There are, they agree in a lot of important parts regarding, for example, CNS involvement, but there are some little differences, for example, regarding the treatment of isolated urine loss. The American ones recommend a short treatment, or for example, in case of isolated hepatitis or thrombocytopenia, where the European initiative suggests treatment. What I want you to know is something regarding the ongoing trial. We see that, there is very few trial ongoing. I found just one, which is again from the Kimberlin group, and is regarding another antiviral, which is rethermovir, giving together with valacyclovir to see PK and safety in infected children. There are quite few gaps in congenital CMV research. There are some scientific gaps, like the limited understanding of host-virus interaction during pregnancy. There are gaps regarding diagnosis, for example, for our, which are pediatricians, the lack of universal newborn screening protocols, which will lead to find also congenital CMV infection coming from reactivation or infection of mothers already positive. And there are gaps in treatment and in prevention. For example, as we already saw, the lack of a vaccine, limited data on efficacy and safety of antiviral treatments. There are gaps regarding the public health and awareness. So this is an important point, the low awareness among pregnant women and especially healthcare providers. Limited implementation of the prevention measure and the lack of public health policies across countries. So what we can do in the future, we can integrate CMV education in prenatal care protocols. We can increase the awareness campaign as we just saw. We can develop clinical trial on CMV vaccine. It's important also the implementation of a newborn CMV screening and to detect some new diagnostic tests for the maternal and neonatal use. To conduct this cost-effectiveness studies to guide the screening and treatment policies, to disseminate the available international guideline for congenital CMV all around, and to implement the existing international CMV registries and the surveillance system. So thank you for your attention.
So today I will give an overview of the Universal 1 study, which is a pharmacokinetic study of an optimized dose ratio of dolutegravir, emtricitabine, and tenofovir alafenamide, with the goal to expedite a universal first-line regimen for all children living with HIV in Africa. Next slide. But before going into detail about Universal 1, I will start by giving some background information on HIV epidemiology, why it is necessary to perform pharmacokinetic studies in children, and what the challenges are, and then provide some background information on Universal study itself, and go into the study methods and expected results. Next slide. So in 2023, there were still 1.4 million children living with HIV worldwide, of which the majority lives in sub-Saharan Africa, as you can see in this figure on the right. And of these children, only 57% had access to treatment with antiretroviral therapy, and only 48% was virologically suppressed. And in adults, these percentages are higher. 77% of adults had access to treatment, and 72% was virologically suppressed. And this is despite the recommendations of the World Health Organization to treat all people living with HIV, including children and infants. And this so-called treatment gap is caused by a number of reasons. Next slide. You can click a few times, I think, Matteo. So among these reasons is the fact that there are some special considerations regarding pediatric treatment. For example, children may require specific strengths and formulations of drugs. Many small children won't be able to swallow large pills, so they need syrups or dispersible tablets, for example. Recommended drugs for children are often also only available as separate solutions or single tablets. And considering antiretroviral regimens often consist of 3 different drugs, this means that there is a high pill burden, or regimens might be complex in terms of administration. And lastly, treatment is, of course, also constrained by the available supply. And since there's a relatively small number of children living with HIV compared to adults, the available supply might also be at risk, and therefore the treatment. So these issues complicate pediatric treatment and show the need for age-appropriate formulations with a complete regimen, which will make administration easier, as well as storage, and specifically for HIV. It will also avoid unintentional mono or dual therapy resulting from individual drug stockouts. I think you can click one more time, Matteo. Yeah, so if we want to develop such formulations with drug doses that are safe and effective, pharmacokinetic research can help with this. Next slide, please. So why do we perform pharmacokinetic studies in children, and why is this helpful in drug development, specifically in the field of HIV? So progression of HIV infection is similar in children and in adults. So if drug concentrations measured in children are the same compared to drug concentrations that are considered safe and effective in adults, we also consider these concentrations to be safe and effective in children. The HIV virus does not know what host it is living in, so the same concentration should kill the virus, regardless of the host being an adult or a child. So by means of pharmacokinetic studies, we want to investigate whether a specific dose that is administered to patients. Now we know that we want to achieve the same drug levels of antiretrovirals in children. However, as you all know, children are not just small adults. So we cannot just calculate the doses for a child merely by correcting for the weight, but we also need to correct for certain factors such as growth and maturation. For example, as you can see here in this figure on the right, the expression of CYP enzymes is different throughout the years in development, and this causes changes in pharmacokinetics of drugs, and therefore also affects the drug levels. Next slide. So now you know why we perform pharmacokinetic studies in children. I also would like to briefly explain how we perform these studies in children. So when a child is deemed eligible for a trial, it receives the study medication for a certain period of time. And after a while, when the drug levels are at steady state, the child will come to the clinic for a full day. And under standardized conditions, the child will take the study drugs in the morning, and throughout the day, the medicine spreads throughout the body. I think you can click 2 more times, Matteo. Thank you. Yeah, so then at specific time points, blood samples will be taken, and consequently, the blood samples will be processed and analyzed in the lab. And the images that you can see here on this slide are copied from a video that was developed together with the Penta Youth Trials Board. which is a model that's developed by Penta to train and support adolescents to be able to be active partners in research. The concept of pharmacokinetics and pharmacokinetic studies might be hard to understand, especially for children. However, if children participate in such studies, it is important and also their right for them to understand what they are involved in and what they also provide assent to. So therefore, this video was developed, which illustrates the purpose and the process of pharmacokinetic studies. And it also highlights the impact of the participants' contribution. So the video was developed for children and with children. And if you're working on pediatric pharmacokinetic studies, then I recommend using this video to inform your participants. And you can use the link shown in this slide to access the video, but of course you can also send someone of Penta or me an email to request the video. Next slide. Yeah, so with that aside, we will return to how we perform pharmacokinetic studies in children. So once the samples are analyzed, we know what the concentrations of the drugs were at specific time points, and we can construct a pharmacokinetic curve that shows the drug exposures throughout the day. Now, we do not want the concentrations to be too high for too long, because this will increase the chances of adverse events. But we also do not want the concentrations to be too low for too long, because this will cause a lack of efficacy and might even result in resistance of the virus if this holds on for too long. Once we construct such curves, we compare these to reference ones from adults or other children to see whether the drug exposure is similar and thus can be considered safe and effective. Next slide. Yeah, so before we discussed challenges in treatment of children specifically, but there are also some specific challenges in performing pharmacokinetic studies in children. For example, dosing for children is often based on weight bands. And children, especially very small ones, grow into the next weight band fast, which means that the dose needs to be changed relatively fast. Also, for safety reasons, there's a maximum allowable blood draw volume for children. So therefore, the time points at which the samples are taken need to be carefully considered, because if you want to accurately capture a full pharmacokinetic curve, you preferably take a few samples before the maximum concentration is reached, but also after the maximum concentration is reached, and the sample at the end. However, because of these volume restrictions, you cannot just take a large number of samples, so this needs to be carefully considered. Then you need EDTA tubes with small volumes that are different from ones we usually use for adults. Because of these small volumes, there's also a restriction on the number of analyses that can be performed in the lab. For example, if you need multiple assays, which is often the case when analyzing plasma concentrations of antiretroviral drug regimens. Next slide. Yeah, so such challenges could be minimized, and the quality of such studies could be improved if procedures are harmonized. And for this, instructions need to be clearly documented and accessible. So at the Radboudumc, we've thought about this, and we believe that a practical guideline or a so-called PK toolbox in study setup and the execution of pharmacokinetic research. So that is what we are currently working on, and this is a collaboration between Penta and the Radboudumc. And at this point, we aim to eventually publish this PK toolbox on the capacity strengthening hub of the MRC Clinical Trials Unit at UCL, as this hub provides very useful resources on the design and the conduct and analysis for different kind of trials. Next slide, please. So now we will continue with information on the Universal 1 study. So we'll start with the background. In December of 2019, the Pediatric Antiretroviral Drug Optimization Group of the WHO reviewed priorities for drug development in children. And one of these priorities was a dispersible pediatric fixed-dose combination of dolutegravir, emtricitabine, and tenofovir alafenamide for treatment of both treatment-naive and experienced children. And this led to the Universal project. The aim of this project is to develop 2 fixed-dose combinations for children who are newly diagnosed with HIV, but also for children who need to switch to second-line treatment. However, within Universal 1, which is part of Universal, we focus on dose confirmation for the development of the combination tablets of these 3 drugs. And as mentioned before, examples of benefits of such fixed-dose combinations are increased adherence and, for example, easier dosing for caregivers. Next slide. Yeah, so first, the dose ratio for this fixed-dose combination tablet was determined by using pharmacokinetic modeling and simulations. And now that these doses are calculated, we need to confirm whether these are actually the right doses. So the aim of the Universal 1 study is to confirm whether the dosing schedule for these 3 drugs that were selected by the computer model achieve exposures in children within each of the pediatric weight bands that are sufficient to treat the HIV virus and are safe. Next slide. That brings us to the methods. So Universal 1 is an interventional phase 2 multicenter single-arm non-randomized pharmacokinetic study. A total of 50 children with a minimum age of 28 days and weight between 3 and 25 kilograms are currently being enrolled. The follow-up is 24 weeks, and all children are participating in the intensive PK sampling. Next slide. In this figure, you can see the dosing schedule for the different weight bands. And as you can see, by using this dosing scheme, the ratio of the 3 drugs is the same in the first 4 weight bands. And aligning the ratios makes it possible for 1 tablet to be developed that can be used across all these weight bands. And now you might notice that in the highest weight band, different tablets are given. And that's because in this weight band, the children will receive the adult dose. So these children are treated with already existing tablets. Next slide. These are the sites that are participating in Universal 1. So we work together with 2 sites in Uganda, which are JCRC and Baylor, and 1 site in Zimbabwe, which is UZCRC. Next slide. So in Universal 1, when the children come to the clinic for the PK day, the drugs will be administered in the morning with a standardized breakfast. And throughout the day, 7 samples will be taken at specific time points. And from the 24-hour sample, we will also collect a dry blood sample. However, considering the time, I won't go into detail about the purpose and the analysis of this sample. Next slide. So once we've analyzed all samples and constructed pharmacokinetic curves for all the different drugs, we can calculate the corresponding pharmacokinetic parameters and compare these values to adult and pediatric reference values. An example of one of these PK parameters is the AUC, which is the area under the concentration time curve, which represents the exposure of a drug over a certain dosing interval, which is 24 hours in this case. Or another important value is the C-trough, which is the concentration of a drug at the end of the dosing interval, which is often related to efficacy and also often shows the lowest drug concentration in plasma over the dosing interval. Next slide. Yeah, so the enrollment of Universal 1 started in January, and most participants already performed the intensive PK visit. So we expect the first pharmacokinetic data soon. And we expect that using the optimized doses for these 3 drugs based on the PK modeling and the simulations will achieve therapeutic and safe levels in children. And if this is the case, the development and the registration of the fixed dose combination will be continued. And this will then have a great impact, since the development of a pediatric fixed dose combination will make drug supply easier and also help addressing the treatment gaps for children living with HIV in Africa. And so these study results might also inform future guidelines and accelerate the availability of state-of-the-art antiretroviral therapy for children. Next slide. So I would like to acknowledge all participants of Universal One and their caretakers, of course, and also the principal investigators and the staff of the centers in Uganda and Zimbabwe, as they have been working very hard on this trial. And here you can see a picture of the consortium, a part of the Universal One consortium.
I would like to introduce our three panelists. So I'm honored to have here the very well-known three panelists. So Vanna Papaevangelou, Hermione Lyall, and David Borger. So I will give the floor to you three to start discussion, or maybe starting with a few comments before we have any questions. I don't know if we have already something in the chat box. I think we don't. So maybe starting with the first one. So maybe Hermione wants to. Okay, I see a hand raise. Okay, so should we?
Yes, do you listen to me?
Hi, Francesca. Yeah, go ahead.
Hello. Yeah, good evening. I'm Francesca Musso. I'm from Italy, from Paediatric unit of Sacco in Milan. And I want to, I have, first of all, very congratulations for all the presentation, because we're really interesting. And I have some question about the CMV presentation, because I do really like this topic, and I would like to share with you some difficulties that sometimes we have since the introduction of the treatment with valganciclovir to the mother, because we sometimes have some difficulty in managing families to explain them that even if they receive a treatment during pregnancy and they have an amniocentesis negative, then we have some cytomegalovirus that are positive at birth. And sometimes it's difficult to explain to the mother this situation, even if we are quite confident that the follow-up will be fine and the prognosis maybe will be fine. But sometimes we have this difficult in managing also in an emotional way the family. And the second one is that if you have some some further specific news about how do you choose to treat the neurological signs that we see at MRA, because it's another hot topic that always is given to the clinician, but it's always a little bit hard to manage also. That's it.
Thanks, Francesca, for the questions. I understand you very well, because regarding the impact of valacyclovir in mothers, I agree that it's difficult to explain, especially the mothers who are not in the medical field, all about these drugs. So we also saw what you are talking about in the Megal Italy study. Because we know that when we stop valacyclovir in treatment, there is a rebound of CMV in the mothers. So we had also these results. So we saw at the end an increased rate of congenital CMV in our cohort, in the treated cohort. But the important news for mothers is that, which is the most important fact, is that those children are asymptomatic. So what we need to stress is that valacyclovir, if stopped as is currently recommended after amniocentesis, doesn't reduce at all the risk of infection, but prevent the complication that we know that are due to the infection in the first part of the pregnancy. So I think I know we have to be confident ourselves about this fact and try to explain to mothers. And regarding the second question, we are just working on this topic because we just, we are writing a review on congenital CMV and regarding the CNS pattern. And there is a score that you can use, which is the Alabama score, which can guide you to the treatment process and can give some information regarding also the prognosis. So you can, give some information also to mothers regarding which need are going to expect in those children.
Thank you.
Thanks, Elisabetta. I think Vanna has raised her hand.
Yes, I would like to congratulate Elisabetta for her very nice overview and providing us her data. And of course, I agree with everything you said, Elisabetta, on answering Francesca's question. I just wanted to stress that we need to be careful when advising women about their prenatal treatment with valacyclovir, that once we stop, this might happen, the rebound and transmission. But we feel very strongly that transmission after the 20 weeks of gestation, like in the late pregnancy, will not affect the baby. We should say that from the beginning. And I think that we should stress, one of the key points of your overview was that, with providing secondary prevention to these women and reducing viral transmission by 70%, this is really a game changer. Few things in medicine have such an effect. We know zidovudine for HIV vertical transmission had such an effect of 70%. So this is a game changer, and we should really stress this to pregnant women, how lucky they are that we can offer them an effective way of preventing vertical transmission. As per the second question, according to the ECI guidelines, we should perform MRI, especially because now we have more data on the significance of white matter changes. And by using the Alarcon scale, as Elisabetta said, we can provide guidance and advise parents about antiviral treatment, especially if we have a baby that we know that is born after a first trimester infection or with an unknown trimester of infection, of maternal infection and white matter changes. Then most European specialists would recommend antiviral treatment, valganciclovir, for this child.
Thank you very much, Vanna. Hope this solved your questions, comments, Francesca, so we can continue with the...
Yes, of course. Thank you.
Great. So I think we have another hand raise, Eric Decluet.
My name is Eric Decluet from Cape Town, South Africa, Stellenbosch University. I first just want to thank the three speakers for three excellent talks. So my question is for Anna, and it's maybe just a comment. So I'm involved in the Penta SNP Africa project, and one of the outputs that we need to deliver is to put together a master protocol and a pharmacometrics plan, and also a database to support specifically neonatal PK studies on the continent. And I'm very intrigued to hear about your PK toolbox And it would be great maybe to compare notes and to share resources. That would be very much appreciated. And then I have a question for Noella, whether the risk factors for mortality changed over time. So clearly many things changed, including when antiretrovirals were introduced. So did you see a change in risk factors over time? Thank you very much.
Yeah,
Great talk.
Yeah, thank you. So yes, we did see a few changes in the risk factors. So some things remain the same, like severe thinness, as well as the severe immunodeficiency do remain risk factors, because even till today we do find children presenting very late in their presentation, and these are children who have missed the boat. I mean, I use the term "missed the boat" because they've not been diagnosed as children and they've come as adolescents presenting for the first time with TB, even till today, even though ARTs recommend it to all. But being in a low middle income country, we do see late presentations. So I think severe thinness, malnutrition, and severe immunodeficiency do hold good, even though ART has been initiated, been rolled out to all. And this is primarily because lack of screening for HIV, and many children have been missed along the way, and late presentation is one of the main reasons for that, as compared to what it was earlier. But still, I mean, drug-resistant TB as well remains, an added factor as well to add to those risk factors. So I think these are the three ones that would be prevalent today, and nutritional and severe immunity and drug-resistant TB. These are still very prevalent even today. And that's, as I mentioned earlier, due to late presentation of these children showing up very late in adolescence and beyond. I hope that answers your question.
Thanks, Noella. I don't know if the panelists want to comment anything at this point for the last intervention from Eric, or anything from the presentations you want to add.
Could I just, it's Hermione here. I just want to follow up on what Noella was saying there with a question in a way. I think when you said that the sort of median age, I think, of presentation was 9 years in your cohort, this is very old. And what I'm worried about is that, we know that susceptibility to severe TB is particularly in children under 5. So I'm worried that there's a whole group of children that have already died of combined HIV and TB and never actually made it to your clinic. So I wanted to know what happens on a national level for antenatal screening and for women getting access to antiretrovirals in pregnancy in India, and for the screening of newborns for HIV in India. And could we say that now we are picking women up in pregnancy and reducing the risk of transmission? Because actually that is going to be the best way to be protecting children from getting HIV at all, rather than waiting until they present very sick with advanced disease. So it'd be good to know what's happening for that, Noella.
Yeah, so the antenatal screening has definitely picked up over the years, and every single mother who shows up to clinic in an antenatal condition is screened for HIV. So definitely we've come a long way in that respect. And then, those babies are given prophylaxis at birth, and those mothers as well are followed up to check that they are virally suppressed so that they don't transmit HIV to their children. And but regard to the newborn screening, every single newborn is not screened for HIV, unfortunately, in our country. So if a mother was missed during the antenatal period, or say suppose she was tested in the first trimester and got HIV in her third trimester, she could have very well been missed, and that baby may eventually get missed and end up showing up at 9 years or 10 years with TB or an opportunistic infection, or even younger. So the antenatal the program has come a long way. We are picking up mothers, and we are initiating them on ART immediately, apparently on the same day that they are tested for HIV and tested positive for HIV. And probably the reason why these children presented quite late is this is retrospective data over the last 15 years. So many things have changed since then, but these children did present at the age of 9 plus or minus 3 or 4 years. Maybe some of them passed away when they were really young, and we missed those. But the vast majority did present at this age, and unfortunately, we did lose some along the way. 58 of them did pass away. But this is the presentation because they've lived with HIV for that long. And maybe these are slow progressors, or, ones that didn't rapidly progress and therefore they reached this long, or, that it's just the way the virus is behaving in the Indian population, just to say the least, really. Awesome. I mean, that's the possible explanation I could give, but maybe you have more thoughts on this, Hermione.
Thanks, Noella. David, you raise your hand.
Yes, thank you, Carlos. I have a question or a comment for Anne. You mentioned the various challenges for doing PK studies in children, but you also are now doing your own study. Have you seen these challenges, or what have you learned from your study so far? Are any new challenges have come up?
Thank you for the question, David. Yeah, I actually listed some of the challenges that we experienced in Universal 1. For example, the drugs that we want to measure in these samples are dolutegravir, emtricitabine, tenofovir, and also tenofovir alafenamide. So the drug and the prodrug and the drug itself. But that means that we need 4 different assays to measure these drugs in our lab. But for the smallest children, for example, we can only take 1 milliliter of blood. So we really need to think about how we're going to measure all these drugs in practice. And also, we also experienced some challenges in standardization. For example, children in the smallest weight band from 3 to 6 kgs, they are often breastfed. So you could imagine that standardizing breakfast or food throughout the day is very challenging for these smallest children. So yeah, thank you for the question.
Thanks, Sam. I think we are about to close this part of the webinar, but I saw Hermione raise her hand. Any last comments?
Two quick comments, well. A question for Anne. One is about who is making the combination, fixed dose combination, the DTG for children, and is it somebody who's going to be able to have a sustainable supply? Because I think that is a really important question. And then the second one is, one of the main issues for adults having dolutegravir and TAF is the question about weight gain and becoming overweight. And I just wonder if you're very carefully going to be monitoring this in this cohort of children.
Yeah, thank you for the question. There are currently 2 companies who are making or the drugs or the fixed dose combination, or at least are working on the development, which are Loris and Viatris. We are currently using 2 separate formulations in the study, and in the meantime, they're working on the development of this fixed dose combination. Yeah, I cannot really say anything about the supply right now, but it is the goal to have a sufficient supply, of course, to treat all the children that need the drugs. And then regarding your second comment, we are monitoring the weight of the children, but I think it would be hard to say within the study what the effect would be from dolutegravir specifically on the weight gain, because the study is only 24 weeks follow-up. So I don't think this time will be sufficient to really accurately analyze these effects. So.
Thank you very much. And I think that you have to be very quick, Vanna, because we are about
Absolutely.
to run the time. But yeah.
I just want to underscore what Elisabetta said about the 2 pediatric trials with less than 50 children, underscoring the need of working together. And of course, we have the registry of the congenital CMV network that helps us look in a bigger picture and do observational studies, but working together with Penta will allow us to go forward on clinical trials and PK studies in the CMV world. Thank you.